Hello, I'm Dr. Russell Libby, and I welcome you to the world of medicine. I think I can venture to say that all of us at some time or another in our lives have felt really, really ill in a way that, well, that conjured up a very frightening possibility in our minds. Possibly some kind of disease that might take a terrible toll on our bodies and our minds. Maybe something that we had to have very frightening surgeries for, continuing kinds of treatments that made us feel very, very sick, and might really sap us of our will to live, help us find ways to sort of explore areas of our being that we never could have imagined. Well, when I think of a disease or a condition that could do just that, I'd have to say brain tumors, brain cancer would be one. We're going to talk about brain cancers and tumors in the head today. We have with us a specialist, Dr. Joe Watson. He's a neurosurgeon here at Inova Fairfax Hospital. And he's an excellent one at that and has a lot of dedicated patients, many of whom are here with us today. We have a courageous group who really have been through what we will learn is the ultimate kind of disease process, one that really does challenge us to search our inner souls and come up with new inspirations and to go through this process. We're going to learn about what happens. We're going to learn about the symptoms. We're going to learn about all of the nuances that they have gone through. So I'm going to ask you, David, I know.
Yes, David Welch.
How old were you when you were first diagnosed, and what kind of tumor did you have?
Well, it's interesting. I have a website called 38 Lemon, which answers those two questions. I was 38, and it was lemon-sized.
Lemon-sized.
Yes.
And what was it called? What kind of tumor?
Grade 2 astrocytoma.
Grade 2 astrocytoma.
Right, but it was in a place where that was considered inoperable.
Well, we're going to hear more about that. And how long ago was that?
That was in December '04.
'04. Yep. So we've got some good time in there to get some perspective.
I'm Birat Nirola, and I had a tumor in February 2006. That's when it was diagnosed.
And what kind of tumor was that?
It was a benign tumor, about pea size.
And where?
It was back in here.
Back in there.
The brain, yeah.
Yes, okay. Well, that's good. I'm glad you're here to tell us about that, too. And you?
My name is Howard Williams.
Hi, Howard.
Yeah, how you doing? I had a benign tumor. It was about 2.4 centimeters in size, and it was over my left optical nerve. And basically, I'm just humbled to be here with you today.
We're happy you are here.
Thank you.
And I'm sure there's some others who are happy you're here too. And you?
Hi, I'm Lisa Harriman. I had been diagnosed in November of 2002 with an oligodendroglioma astrocytoma mix in the brainstem. This is the first time an oligo had ever been found in the brainstem area. Usually it's a right front temporal lobe thing.
And I guess just being able to say the name of the tumor is,
It took me a good while to learn that
it's a good test as
one.
to how your neurons are working. That's pretty good, too.
Hi, my name's Larry, and our oldest son had a medulloblastoma diagnosed in May of 2007, had surgery with Dr. Watson, and is doing fantastic. He's back at school.
So he's in college, and you're here to tell us about what he went through.
My name's Russ Fair. I was diagnosed in July of '08 with a tumor on the pituitary gland that was pushing on the optic nerves.
Okay, good. And it's good to see you well.
My name is Kevin Takiguchi, and Dr. Watson is my doctor. My tumor was diagnosed in 1993, and it remains fairly stable until the end of 2005, where I took another MRI, and it showed that the tumor was growing again. And I originally went to Johns Hopkins, and they didn't do a very good job. And later we found Dr. Watson right in our backyard at Inova, and he did a wonderful job. I can see a little bit now, and my memory problems are very little now.
Well, we're going to hear more, and that's a great story. Actually, it's nice to hear that we can compete with Johns Hopkins here in Northern Virginia, of course, and it's good to have that testimonial here from you. Dr. Watson, when we talk about brain tumors, I mean, there are lots of different types. Give us a sense, how many people a year in our country will be diagnosed with a brain tumor?
Well, unfortunately, it's a common problem. It's not common for your average practitioner, but they tend to funnel in, of course, to the specialists. So it's something that keeps me busy. You know, we'll see 10 new tumors a month, unfortunately. It depends on the type, of course. And when most people talk about brain tumors, we're talking about primary tumors of the brain. But a huge problem is tumors that spread from elsewhere to the brain. But the numbers are high, you know, on the order of 50,000 a year for primary tumors and probably triple that for metastatic ones. So, you know, it's always one of those diagnoses that strikes some fear.
Right.
But you have to get to know it a little better to understand what you're facing.
It's interesting. There are some unique features, and of course you're saying the metastatic ones, and the tissue-type tumors that are most commonly associated with the metastatic tumors. Lung
is by far the largest. And when you think about the physiology, it's clear, but the lung acts as a big filter, so a lot of tumors that spread usually have to go to the lung before they go to the brain. Melanoma is one of the exceptions, but and that's another bad thing we deal with. But we could spend the whole time talking about metastatic tumors, but I think, again, when you think of brain tumors, what usually we're talking about are the primary tumors. Some of those are very treatable, very curable, and others are much more difficult.
Well, and we heard some people say they had a benign tumor. I guess anything growing in your head is hard to consider benign.
Right.
As they
it's
say.
A closed space, so benign pathologically doesn't mean benign to the person. You know, It can be very malignant. It can cause great harm. It's
so there
arguably
are
the most important organ.
Well, in that 50,000, let's say, are the majority of them malignant types? And I guess when they say malignant, you think of those cancers that really are more aggressive and grow more, let's say, more rapidly and in ways that are harder to control.
Right. In adults, unfortunately, statistics are that if you have a primary brain tumor, the odds are 60% or so that it's going to be the worst type, the glioblastoma, which is the highest grade astrocytoma. We grade astrocytomas from 1 to 4, 4 being a glioblastoma, and we consider the grade 1s benign histologically and behaviorally. And there are other tumors that are on the cusp of benignity to being worse off, the grade 2s, and then grade 3s. It's a spectrum.
Right. Well, fortunately, we have some great sound issues going on here.
Issues.
Hopefully, they haven't been ones that hurt anybody else's ears other than our own. But nonetheless, you know, one of the things that you were talking about, a tumor at your pituitary?
Yes.
So tell us where, looking at the head, the pituitary is.
It's right behind your nose. In fact, the word pituitary comes from what they used to think it did, which was secrete mucus. That was what because it sits really at the back of the sinuses. And before we understood it, they derived its name from what they thought it did, with secrete mucus, which it doesn't do. But the pituitary is made up of two parts. One part's an extension of the brain, the posterior lobe. The other part is an extension, really, of the oral mucosa. And there's a gland there, which is sort of the master gland. Tumors arise from that. And normally, they don't affect the brain necessarily unless they get very large. Unfortunately, Mr. Fair's, being a little humble, his tumor had grown up into his brain, into his third ventricle.
Well, give us a little idea as to what kinds of symptoms you had early on when you really weren't sure what was going on.
A couple of years ago, I began to have some visual impairment, as well as some significant headaches on occasion. But I remember driving through the tunnel in Baltimore one time, and I've driven that tunnel many, many times, and it all of a sudden seemed much more narrow than it used to be, and I was actually somewhat intimidated by the tunnel, and that was several years ago. and I had some eye exams done, and they didn't identify any change in my prescription. But what I didn't realize at the time is that it was really affecting my peripheral vision, and as the tumor grew, it began to close in on the center of the eye. So eventually, in July, I went to the Department of Motor Vehicles and failed the vision test. And at that point, I went to the doctor. Yeah, it doesn't happen often, apparently. So and saw a doctor, and he ordered an MRI as well as having me go see a retina specialist. And the MRI showed the tumor was fairly good size.
So it was mostly headaches and visual changes.
Yes, yes.
Which are big issues. How about for you? What kind of symptoms did you have early on? Do you remember?
Hey, I didn't have any.
You didn't have any?
I didn't. I had one small symptom. It was Labor Day weekend, and I had a little bit of numbness across my cheekbone. Thought I had a sinus infection. Went to a little urgent care facility for some sinus medicine. He looked at me and said I didn't have a sinus infection, and disappeared for a while and came back and said, well, you know what? That's a presenting symptom of MS. You might want to go to a neurologist and just have it checked out. I just happened to know a good neurologist in the area. Went and talked to him. He laughed at me. I don't have MS. And, just to make me feel better, he sent me to get an MRI. And they found the tumor in my brainstem.
It didn't make you feel any better?
It didn't make me feel any better. They found it.
To make you feel better, he sent you to get an MRI. That must have been a pretty frightening moment for you.
It was, the way they talked about it was 3.5 centimeters, so it was fairly large, and the brainstem is mission critical to all your body functions, and so it was a very dangerous area to have a brain tumor in, so it was very frightening.
And so for you, it was basically just some strange numbness over where you would have a sinus?
Very small, right on the cheekbone.
And no headaches?
No.
No nausea? Nothing else?
No.
And your son?
He came home from his freshman year of college, May of last year, and no symptoms at all upon arrival. And then within a couple of weeks started to have some pretty intense headaches. So we took him to have an eye exam, had that checked to see if there was anything there. And no answers were resulting from that. So we went for an MRI on a Thursday evening, and we got a call Friday morning early to go see a neurosurgeon, and Dr. Watson was available. We met with him on a Friday. And the following Wednesday, he had surgery. It was malignant medulloblastoma in the cerebellum, and he then went to Boston for 2 months. We moved Yvonne and him to Boston for 2 months, and he went proton radiation there every day for 6 weeks, and came back to chemo here in Northern Virginia at Nova Hemoc, and he's back at college now.
So his was basically headaches. Were they something extraordinary?
Intense. The last week was absolutely intense.
So they were escalating over time?
Yeah, in a matter of probably 10 to 14 days, very quickly. And it's a childhood tumor. It might have been there for a number of years. We don't see these type tumors in 30, 40-year-olds, but it was just one miracle after another from that Thursday evening to present.
Did he have nausea, vomiting, anything of that nature?
Not at all.
Interesting. Sorry. And David, your symptoms. You were a busy man. Still are a busy man, for that matter.
Well, busy man. I was doing the 80, 90 hours per week. Those kind of gigs at our business. But all of a sudden, I started having some seizures. I didn't know what they were. I would just it would wake me up. I was still cognizant, but my body would stiffen up, and I'd run to the bathroom thinking I was going to vomit, and that wouldn't happen. And then one night I woke up, and there was blood all over my lips and on the back of my head, and I felt like I just ran a race. My muscles were really, really tight. So I went, did a logical thing, and went to Target and got some NyQuil. I figured I'm just working too hard.
This is too much.
Wow. Yeah. And it turns out that they were grand mal seizures, and so I bit my lip, and that's what's caused all the blood, and my banging my head against the board of the bed, and that was caused bleeding, and my arms and legs just spazzing out caused all the aches. but it was friends who told me to go to the hospital. They said they could see.
Total denial.
Yeah, I didn't. Well, I didn't know.
Stressed guy working 90 hours a week.
Well, I have two friends that were very much brain tumor victims, and I have pictures of arm around arm, and so I figured I was pretty safe.
Yeah.
So
the statistics weren't with you there.
I was very naive.
Was he really naive?
For a family who prides itself in being preventative care, I mean, my kids have, among 3 children, 1 cavity, and every test that you should have, they've had. But brain tumors were not on our radar screen. So I guess we were very naive, educated people who know how to take care of themselves, and we were naive about this.
And I'm sure you've had quite an education since. You had a small, little benign tumor. What did it do?
I was out with my friends. I don't remember going out there, but after that, I remember just a little bit of stuff. Then I suddenly had a seizure. Then after that, I don't remember anything for until 12, 13 days or so. Then I woke up, I was in hospital, and then I knew that I had a tumor. They did a CT scan, and they couldn't sort it out. So later on, the MRI they could see through the MRI that there was a tumor.
So, were you unconscious for that period of time, or you just have no memory from that period?
I was unconscious.
Okay, so that was a small tumor that really impacted your brain and its function.
Yeah.
You have a pretty interesting story from your initial presentation. What was happening with you? What kind of symptoms did you have when you first had your diagnosis in '93?
It was mostly vision problems, but I didn't really notice it. I was on the freshman lacrosse team, and my dad noticed I'd miss a pass, in my blind spots, but I didn't. I thought I was just not playing well, and it wasn't, until I started playing football my sophomore year that I didn't really notice the symptoms until after this first surgery.
Okay. So you had some changes in your visual field that you ignored and really didn't progress much until the following year.
I didn't notice it because I was able to compensate for it by moving my head around to be able to see stuff, and I guess by playing sports it kind of had to.
And you never had headaches? You didn't have any other symptoms?
No.
Oh, yeah. It's interesting. And when things started for you, what was going on?
I just became very lethargic. At first, I guess you could look at it as being denial in terms of myself, but it was my wife that basically picked up on a lot of the missteps that I was having. Basically, I wasn't stepping around correctly. I couldn't feed myself correctly. I was grabbing the fork and I was taking my time. And she knows I love to eat, but when she started looking at me, she was like, something is truly wrong with you. And of course, I go back and I regress and say, hey, look, it was all about denial for myself. Then she had a couple of my friends come over, and they persuaded me to go to the hospital over in Potomac. And once I went over there, they did a MRI, and that's when I was blessed to meet Dr. Watson. After I woke up, of course. But I never knew what led or where I was going in terms of going over to the hospital. But after I awoke and realized that I did have that and had an opportunity to meet Dr. Watson, he just basically said, I was your neurosurgeon. Then I just sat back and everything sunk in. And I just said, man, I'm blessed, and most importantly, I'm humbled by the whole experience, and I think we all are. But
and most importantly, he was there, right?
Yes.
Yeah. I'm sure it probably took you by pretty big surprise.
Yeah.
I mean, you thought he was just being...
Well, actually, I thought he had a stroke.
Did you really?
Yeah,
oh, so you were noticing some real changes.
Oh, yeah. There was a lot of things going on. He was falling, vomiting, but denying that he was vomiting, but the smell, and he was distorted. And I think what really got me was Mother's Day, when my son purchased a card and something for him, and the way that he wrote on the card, the signature was like a 5-year-old wrote it, and then I got scared because he just
Something
wasn't
was
just
really wrong.
Yeah.
And you, how old were you then?
I was 29 years old, like last year.
So you were able to sort of see what was going on. Was it clear to you? Were you observing there were?
Yeah, he was having headaches, couldn't walk. Towards the end, I actually was feeding him outside, and I was like, "Dad, you got to go to the hospital. It's ridiculous."
So he was just telling us, "I was fine, you know."
Yeah, I mean, I was
my friends
actually
came over and they told me something's wrong. Go to the hospital.
I was actually feeding him, and
so he's still in denial, huh?
Still,
okay, that's good.
Actually, I don't think he knew what was going on.
Yeah.
It's kind of like he was dying slowly.
Well, we have some pretty. Well, there are two things here. One is we have a set of symptoms that seem to be fairly uniform, and there are probably some more that you can tell us about. But also, some people didn't feel that terribly ill, which is also kind of a frightening concept as well. Tell us a little bit about those symptoms. What are the common symptoms that people might have?
Well, sure, there's a theme here, and where some of this comes from is the brain's unique. It perceives for the rest of the body, but it has very little ability to do it for itself. In other words, it doesn't feel pain. You can operate on someone awake. I don't like to do that, but you can, because you can cut the brain without the person experiencing pain. And it makes it a problem. It's not really denial, but it's the organ that's supposed to notice these things that's affected. So it makes it difficult for the person to know what's going on, and things go on until you have a seizure, or there's something that's more discrete. Classic symptoms: terrible headaches, usually in the morning, seizures. Occasionally you'll present with some more focal neurological things that you really do say, wow, that's not right. But in denial, that is the right word, but the explanation is a little different, because it's a problem with the brain itself.
So they're not really noticing some of the symptoms that other people are noticing about them. So
right, and often you'll rely on family,
right.
Or friends, and it's much like stroke. And one of the problems we have with stroke is getting people to come in, right, because it's the diseased organ that's supposed to do all that, and you can't expect it to.
So, and that's an interesting concept in and of itself, because the fact is, when you have a problem with the brain, like headaches, for instance, it's not really the brain that's hurting. It's the structures around the brain, the blood vessels, the tissues that support the brain, that have the nerves in them that give you the pain, the muscles on the outside, and all those sorts of things.
Exactly.
So that's an interesting concept. So it's okay for you to be in denial then. Absolutely. We accept it. It's fine. So you never really had much more of an awareness than going to the hospital and then coming out?
Absolutely. I just did not really realize what was happening until I had an opportunity again after the operation, and then after my family came in and started speaking to me about what had happened in terms of me having the surgery. But leading up to that, it's just that you operate as you do normally, though you think you are. You're really not. Now that I, regress and think back. And I can give you one quick story where my wife had me, and I'm going to play this out. I was preparing myself to go to work, and we both get up about the same time. I go into the shower. I couldn't get out. That's what she had told me in terms of, it's just a regular little shower stall, but I couldn't find the daggone opening. So it was funny because my wife comes in and says, "What are you doing?" So I just fall out, and then again she knew something was wrong, all on the floor,
So, and you were just, it's just one of those things. You were going to keep on going. Yep. Yeah. So you had your tumor removed probably at the point when you came out of surgery. You were probably quite relieved that it had already happened and that you didn't have to think about going through it.
Well, it's something that you really don't think about as you're going through it,
right,
but you do think about after it happens, and then you really put things in perspective. And personally, from my perspective, is that I'm just, happy to be here. But in the same token, you also look at the landscape around you. And when I went through my rehabilitation, it really made me resonate that we are very fortunate, because there are a lot of people that are less fortunate than us that are going through the same thing, but it's a little harder struggle for them to come back. And that's the one thing that I took from this whole experience. So, you know, you're just happy to be here.
Yeah. You have to be thankful
Absolutely.
for those healthy days, for sure. Now, David, going back to you went through a fairly extensive process with your tumors. Tell us a little bit about how that all evolved and how it was diagnosed and what you had to go through with your treatment so far.
The tumor itself was buried in the basal ganglia area. Well, I don't know what these words meant beforehand, but you know, it's just hard to get to, and you have to go behind the
Sylvian fissure.
Yes, thank you. The Sylvian fissure.
Oh, well, of course,
and that's,
everybody knows where that is,
well,
right?
it's basically where the brains connect,
Yep.
and then you have to pull it apart, and then the problem is you have all these blood vessels, and you could walk away not being able to walk, and not being able to talk. So Dr. Kelly had invented a tool. He was able to get. We thought he could get a lot more, but we got about 50% of the tumor. Then that was on 5/5/05, so very easy to remember the date. Then went for 2 years on Timidar chemotherapy, which is a long time, and actually reduced the size. And then in December of 2007, it exploded into a fast-growing tumor, and we did another within 7, 8, 9 days, somewhere around there. We had another surgery, then went to radiation, and then chemotherapy, and one type of chemotherapy, and then ever since we started talking about this program, new things were found. So just last week, we found out new tumors in growth in the corpus callosum. Is that
Callosum.
Callosum.
That's right.
Callosum.
That's pretty good, though.
Yeah, callosum. And we're trying to get on a clinical trial. I'm within one blood count of getting in this clinical trial.
And a CAT scan, because his tumor, he had 2 bleeds shortly after his second craniotomy, and he has to be 6 weeks out, 6 months out from a bleed to qualify for the trial. And they want to make sure that the tumor is not oozing blood at a subclinical level, a level where he doesn't have any symptoms. So the CAT scan will show that. But this one, the corpus callosum, is basically you have 2 separate brains. And the corpus callosum is a fiber tract that runs from between the 2 brains and allows them to communicate. And he said, Dr. Fine, who's neuro-oncologist, said any surgery, radiation, cyberknife, anything in that area would be neurologically devastating. So the stakes in this game have just been raised. Yeah. So.
Yeah, it's the thing. This thing is like it's a never-ending story, you know. Because when you think we thought we were going to get to a place where it was a chemo holiday, right. You know, I actually had a couple months where we're not doing anything, and then bam, you know, just like that, right. In a week, changes very quickly, where there's urgency.
And I mean, there are lots of questions to be asked from that perspective. You know, is it the chemo that was keeping things under control and stopping it, allowed something to happen, or was it happening in spite of the chemo? I'm sure that you have a lot of unanswered questions that are going to never be easily discerned.
The exploding part of the brain in December of 2007 was an area that we had been watching and we knew about, and we reduced that by 90%. And you know, with all the surgery, radiation, and chemo, but this is another area. You know, so that's the thing. The analogy that Dr. Fine, and this is probably a very clarifying comment from Dr. Fine, is that these cancerous, you know, if it's not a benign tumor, the tumor is actually like a bucket of sand, and you're standing in front of a lawn. And it's not just that bucket of sand that you can remove. It's like you take that bucket of sand and fling it all over the lawn. Now, pick up every single pebble that's there, and you're cured. But you're not going to be able to find every one. And that one little one can grow into something very large.
Well, I'm glad you can articulate as well as you can, considering all that you've been through, treatment, surgery. Obviously, they haven't touched parts that I can discern have had a
It's
significant
strange.
impact on you, which is a great thing.
Oh, she's corrected me a couple times when I've said colossum, callosum, you know.
Well, I think anybody
You know?
would do that.
Well,
for that
I
matter.
corrected her too, so you know.
Oh, okay.
It's a normal brain.
Yeah.
Great. It's a normal way to go about it. And you had neurosurgery as well?
Yes, and Dr. Watson did it.
Okay. And this was being a benign tumor. Did you get treated in any other kinds of ways?
No, it was in the surface, and after the surgery, it mostly, I guess, it was taken out. And there was an MRI done about 8 months ago, and the MRI, you know, when they checked it, they found out there was only scar. But as Dr. Watson said, I need to keep doing it at least once a year, or twice a year or so. So I need to do it again and see if it has developed again or not.
So you learned how to descend into the MRI machine.
Yes.
Yeah, that's another experience in and to itself. So we're talking about the kinds of workups. I mean, most of these people have had CT scans or MRIs. That's not a hard way to figure it out. How do you localize a tumor when you do have to find where it is exactly?
Well, this brings up a real important point about the primary brain tumors, and one that's difficult to understand. And you need analogies like you've given us from Dr. Fine, which is a very good one. We see things on a scan. We see a confluent area, a tumor, and we can target that at surgery. We can remove it. But the tumors that aren't benign or the lowest grade, they spread out. They send out and into brain that's functioning. Now, areas of tumor that are just solid confluent tumor, there's no thinking going on. You can take those out. But what you can't do is take out every little grain of sand, every little cell that's spread. So you rely on other methods of trying to get a cure. And it's not a focal disease, and it's a difficult concept for even peers of mine, colleagues and fellow doctors, who you see something on the scan, well, why can't you just take that out and cure it? Doesn't work. Your body has to fight it. You need some help, and there's some promising stuff. And you need more research. And one of the great things about, besides you've met some of my patients, they're fantastic. It makes me happy. But one of the things that they haven't mentioned is many of them have donated their tissue that the pathologist didn't need to the lab. We have a great lab at George Mason where we're looking at pathways. We're looking at finding out why, what makes a tumor, and we're trying to figure out, well, that's going to lead to better, more specific treatments. And we're seeing some of that, coming out in oncology these days. But for the moment, we're left with the traditional treatments, which do have effect, the radiation, the chemotherapy. But the brain is a privileged site. The brain excludes toxins. Your brain keeps out poisons, and most chemotherapies are poison. So we've had a hard time treating brain tumors. We do. It's a real struggle. So we need to be smarter. We need to figure out more specific biological ways of treating these things.
So the traditional way, of course, cut away the scalp, take out a chunk of skull, push things out of the way, find that tumor and pluck it. That has really been replaced by some fairly sophisticated evolutions, robotics, I guess stereotactic radiation, the gamma knife. Tell us a little bit about some of the advances that we've seen in the approach to the surgery.
Well, surgery has gotten better. We have, the computer age has made it a lot easier for us. I'm old enough to remember the old days where we'd take I'd shave half the head and take a huge part of the skull off and sort of look around, try and find these things. Now we have computers in the OR. We get a scan often right before. We put that into the computer in the OR. We tell the computer where your head is when your patient's asleep, and it guides us right to the tumor. So my life's a lot easier. Again, with most of these tumors, though, it's not a focal disease. Even stereotactic radiosurgery or gamma knife, it's focal treatment, and for many things, many tumors, it's not it's not effective for some. It's fantastic. It's revolutionized the treatment. But again, these primary tumors, we have to treat the whole brain, really. And you need something, and you need help from the patient. Their body has to fight it. But there's great promise. Immunotherapy, biological therapy, but we need to understand the tumors a little bit better, and we're close.
So, and you talk about immunotherapy, and I know that that's a pretty interesting new landscape in the treatment of these things. Give us a little perspective as to how that works.
Sure. I'm not an expert in that, but I think we all know the stories. In fact, we have one here in the audience where mind over matter, where your body fights the tumor and ultimately call it what you want, but mind over matter, there is a connection between the immune system and the brain and their attitude. So we don't understand that. I wish we did. And there's great research in that area, and there's research in more sort of grounded areas where vaccines are being used. Melanoma, we've had some very good success, and hopefully, we've been trying that with the primary brain tumors. Haven't had the luck yet, but it's
so the vaccine.
In
That's an interesting cancer treatment. So you'll take a cancer cell from a tumor, an actual tumor, and you'll stimulate an immune response from some tissue that will then create antibodies that you will then use against that tumor.
So get your body's immune system to fight it in a very specific way.
And they like blood vessels, and you use medicines that sometimes inhibit that kind of growth too.
Well, right. There has been success with chemotherapy that's biological, Avastin specifically, that targets new blood vessel formation. And one thing about a lot of these higher grade tumors is they make abnormal blood vessels. And so you can use that. And we're just starting to look at that in depth in the brain. And there are ongoing experiments. David here mentioned a protocol, and that's going to be part of that. So we're on the cusp of that too. It's exciting.
It moves fast and it moves too slow at times.
Right.
And I know he's probably talking about you for some of this, is he?
Yes, he is.
Yeah. And when we talk about the sand, you've had the tumor that can't be easily gotten to, and you've had the medicines that made you feel so bad that you throw up your arms and say, I'm better than this.
Yes. They removed a 3.2 centimeter tumor on the outside of my brain stem. Then it had single cell strands of cancer cells growing around the brainstem and into it that they couldn't remove without causing serious damage or a fatal result. So the doctors after surgery told me I wouldn't live a year. My surgeon, Raphael Tamargo, did tell me that he would like me to do radiation, but he wanted me to remember that chemotherapy is all experimental and that it was really up to me to decide what I felt best about. I did the radiation. I did 4 months of chemotherapy and was absolutely miserable. I was very sick, very nauseous, very tired, and was having just bad reactions to it, which is kind of unusual for Timidar, but I didn't respond well. So after 4 months, against all my doctor's wishes at Duke, at NCI, Dr. Fine, everybody up at Johns Hopkins, I chose to take myself off of chemotherapy and contacted a doctor who was a nutritionist for brain tumors patients, and they put me on some special diets and things, and I made up my mind. I think the brain is the most powerful thing in the universe, and if that's true, then I certainly should be able to use it to fight this. And chemotherapy kills other cells. I've seen a lot of people have a lot of damage from the steroids, from the chemotherapies, and I figured if I had to fight this on my own with my brain, every other cell in my body better be ready.
Right. And it's interesting. It's a push and pull no matter what.
Right.
If it's surgery that's going to take some healthy tissue, you're going to have to deal with that. If it's chemotherapy that's going to make you feel miserable and knock your hair out, knock your intestines wild, make you feel terrible, but give you some extra time and quality of life, it's a real fine balance there.
Exactly. And Dr. Watson brought up a good point. You know, in my history, I've now going to be 6 years out in November from my surgery. I have been on MIT's web email reflector and watched thousands of patients correspond with doctors and among themselves about various symptoms, various drugs, various reactions, caregiver issues. And during that whole time, I saw several patients die from complications of steroids and things like that. And I think that it's very important that you realize how powerful your attitude is. The other thing that makes me really sad that I see is some people get the diagnosis and they roll over and die. They don't fight. They don't say, I can beat this. They listen to the doctors who tell them they're going to die in a year, and they don't do anything to make an effort mentally to prepare to live beyond that, which is actually a whole nother difficult situation.
Well, and I'm sure that finding the inspiration is sometimes difficult, but you look like you're living a pretty full life. I mean, if looks can tell you that.
It's tough. You know, I'm not going to make it sound like it's all glamorous at all. I think once you find out you are going to live and you fight this thing, you find out there's a whole nother set of problems. You've walked away from your world. You've walked away from your career. Basically been forced away. I don't know if anybody's ever taken a 2 or 3 year break from their career to fight cancer and then tried to go back. It's very difficult. You have medical bills that you thought you were never going to have to pay because you weren't going to be here. I've used up all my 401k, every penny of retirement on medical bills and chemotherapy. There are just issues, whole new sets of issues living that are separate from the ones that you have to deal with thinking that you're going to die. So I tell people frequently that I think it was tougher to live than it would have been to die. But, you know, like you said, you have your motivations and your inspirations. And
let me ask you, and I want to talk a little bit more about this a little later, but the diet, for instance, the only things I've read about are antioxidant diets and looking at certain types of foods that may have some inhibitory effect, cruciferous vegetables and things of that nature on the progress of certain types of cancers. But what is the basis of the diet?
You know, the basis of the diet that they ended up putting me on was to build a strong body, and it would be the very basis that you would look at for nutritional things. The first thing they said to me, and I still haven't found out the answer, maybe you know this, but the first thing they said to me is no more Diet Pepsi. I hope you don't have a sponsor with Pepsi, but
no. I wish we had a sponsor.
They were adamant.
I wish it was Pepsi for that matter, but no.
No, they were adamant. No more diet sodas. No more. They preferred no more soda. Period. But they were adamant. I was a big Diet Pepsi drinker, so that was a big one. But they put me on a lot of fruits and vegetables, a lot of good carbs, whole grains, things like that. Just a very, very healthy diet, and it seems to be working. I'm still here.
So, and that's the testimonial that we need from that point of view. Did you try any alternative types of treatments for yourself through any of this?
No, I went to see Dr. Watson probably a week after the tumor was identified. The MRI report came back, and surgery took place 3 weeks later. He used, I think I say this right, a transsphenoidal surgery. It was on July 31st that I had the surgery, and here I am 4 weeks later.
Wow.
He believes he got
fantastic.
it all. Yeah, I think I'm humbled by these stories. Mine was quite successful, probably a tribute to Dr. Watson's skill, I'm sure. But I'm fine. My vision has been restored, and I'm fine.
When you found out about him having a brain tumor, did it take you to the floor?
No, it sort of put me into action, and I was on the internet immediately and spent most of my time on the internet reading everything that I could read.
So you took control of the situation.
Yes.
And were there any changes that you've noticed in his personality prior to or after the surgery?
Personality?
Yes.
No. I mean...
This isn't a marriage counseling show, but I'm just wondering if there were any changes that are a consequence of having neurosurgery that you've noticed for him.
Nothing. Nothing at all.
Okay, that's good.
Yeah.
Except he looks like a guy who wasn't particularly boisterous in the first place. So I imagine that he's still a humble man and now has a lot more respect for his humility. You went through a lot of changes through the course of your cancers, and I know that you've been there taking him through, helping. Obviously, he was an athlete, student athlete, and he was making you proud, and then he had to go through a lot of this. What kind of changes did you observe through that whole process?
Most recently, or the one in high school?
Well, I'm happy to hear the more recent one, actually, to see how you feel it's changed you.
It's much better the second time, mainly because I have better friends now than I did in high school, and I think all of my friends supported me through this one and made it a lot easier. But first, I have no memory of after the surgery. When I woke up from Dr. Watson's surgery, I thought I was at Hopkins. So I'm so thankful every day that my dad went to the Dr. Lander recommended I go to see Dr. Watson instead of going back to Johns Hopkins.
So he's gotten better from that point of view.
Yes, one of the positive things about Kevin, and I think you hear from the rest of them, is that they had this very positive attitude. And so when he had his first operation when he was a sophomore in high school, as soon as he completed his surgery and got recovery, he wanted to go back and play football, all those kinds of sports. And he studied hard, went to college, but it's always that positive attitude that he's going to do better. I think he could have qualified for, I guess, handicap, because he had some vision loss. He said, no, nobody's going to know that I've got some vision loss. So he never said why me or anything. He just moved on and was very positive about it. So I think all the people who's got very positive attitude can probably beat a lot of the challenges.
The challenges of it. And it's interesting that you say that, because obviously he's proud of his ability to take care of himself and to do these things, and obviously there's a lot to it. Sono Pancholi is a neuropsychologist. She actually works with me in my pediatric office, and we take care of kids with neurobehavioral disorders, and I rely on her to do a lot of the testing and a lot of the work to help understand and identify what the problems are. But as a neuropsychologist, which is a special category of psychologist, you will see patients who have gone through brain surgery or cancers or treatments. Tell us a little bit about what it is that you do and how you help with the care of these kinds of patients.
Well, the specialty of neuropsychology is looking at brain-behavior relationships. So you're really looking at the external behavior and then extrapolating from that what may be going on with the brain. When in cases of brain tumors and treatments and all that, there can be so many different types of cognitive deficits depending on where the tumor is, how big it is, whether it's malignant, benign, what the treatment has been for it, whether it was resection or radiation or chemo or a combination of all of the above. With radiation, there's problems with decline of cognitive function over time because it affects the brain. So there's atrophy sometimes. With chemotherapy, you have, as Dr. Watson pointed out, it's basically a poison. And so you have what's called neurotoxicity. And it causes different types of cognitive deficits. And they can really range from memory deficits to problems with language, problems in speed of information processing, attention, concentration, even personality changes, which you had mentioned earlier. And all of that will vary from person to person, from tumor to tumor, and also depend on the type of treatment. What happens with the neuropsychological evaluation is ideally, and this doesn't always happen, but ideally you would be, if you knew that there was going to be surgery that was going to occur, you would try to have what's called baseline testing. And that establishes that person's cognitive functions at that point in time. And they may be diminished because they have this tumor. And after the surgery, then, you want to go ahead and do the testing again. Obviously, if the person's in a coma or whatever, you're not going to get baseline at that point, and you can get the baseline after the surgery. But the baseline even after the surgery is important to get, because if you're then going to have that patient in any kind of, extended treatment through chemotherapy or radiation, it's going to affect their cognitive functioning. As I said earlier, with radiation, there's, atrophy of the brain. So what happens is that you may not see the deficits right away, even 5 years after, they've stopped radiation, that's when you might start to see the decline. So it's, it can be kind of a gradual decline, or, the decline doesn't occur until a few years later. With the chemotherapy, it's different, where you see problems more immediately, but once you take away the poisons, you have some resolution of, the deficits, and some of the deficits sort of go away, and so you regain some of the functions. But a lot of times the neurosurgeons, the oncologists will want to see serial testing, so every year see testing, especially in cases of radiation therapy, to see if there is that gradual decline. If there is, they may discontinue treatment if it's still ongoing, or, if there is, then recommend some sort of cognitive rehab to help the patient then regain some of what they're losing.
And, of course, Dr. Pancioli, interestingly, also helps down into Walter Reed. She helps deal with some of the closed head trauma from our soldiers who come back with a lot of deficits and a lot of issues, and really have helped a lot of people that way. Are you able to get many assessments? Are you able to get people who have the opportunity to get assessed before they have surgery? Have you been able to do some of that?
Sure, it's particularly important in people who are still working, still in school. So it is an important consideration. Many things take priority. Often, as Dr. Pancioli mentioned, that you may have, you're not going to postpone your treatment waiting for neuropsych testing necessarily. But it is an important parameter to measure. It can help you measure response to therapy. Help you get a feel for the recovery that's going on.
I just finished with my fourth year in a row of neuropsych testing and fourth year in a row of speech pathology testing. So this stuff is real, and when they throw the hard stuff at you, it is really hard. I mean, she doesn't joke around, and it's tough stuff. But if we knew, when I finished the tests last week, we didn't know I had a new brain tumor that was growing. And it really becomes important to see and have a comparative way of comparing, 4 years ago to now. Because I know there are things that have changed, and I've compensated in all kinds of ways. But what was it back then? It seemed like a benign thing to do back then, but now we've got the data.
That's really important, because you would not, even as a physician, you would not, you'd be amazed if you saw when David is not able to compensate. I mean, he's a walking thesaurus, so if he can't find a word, his tumor is close to the speech area and the motor strip. He's got a wealth of synonyms that he can substitute, but when he's in a situation where he cannot do that, then the deficits are more much more apparent. And I know you have discussions during testing about his compensatory techniques. I mean, he has so many little tricks and using his fingers and how to remember things that they said that they weren't even going to recommend therapy because he's done a better job.
Fortunately.
Well, it's, I learned to compensate in these areas.
I would love to hear, do you have alternative and complementary routines that you recommend for people?
Not per se.
Not per se. I know that there's acupuncture for certain types of pain or other sensory deficits.
It's interesting. It's a little more accepted in other areas of our practice, such as back pain syndromes. But I encourage people to try everything. There's a lot of people And there's a lot of validity to other things that are going on. Certainly we don't understand everything. We have a philosophy that we learn through medical school. It's grounded in science, but it certainly isn't all-encompassing. It doesn't understand everything. We know that. One thing we know working with the brain is that our abilities to understand the world are very limited by this organ. A lot of stuff going on we don't understand. So, yeah.
David has gone with mainstream medicine, but he also exercises an hour and a half he does one day he's walking an hour and a half, the other day he does upper body exercises. After he got off steroids in December, it took him 2 weeks to do a half of pull-up. Now he's up to his usual 15. He doesn't drink sodas. He eats organic, high fiber.
No beer.
No beer.
All right.
Yeah, I gave it up in 2004. I know. It's a controversial move.
But you're dealing with a tumor. I mean, if there's a tumor lottery, some people in this room have won the tumor lottery. It's like, please let it be a meningioma or pituitary tumor or an acoustic neuroma. There are, 122 different types of brain tumors, and I certainly believe in the spirit and the will, but there are some boogers that are nastier than others.
Yeah. Well, and as we're coming down on time, I know that as it's changed your life so dramatically, you've searched for other means to achieve, well, just internal satisfaction, gratification, and you've really taken on educating and participating in helping people understand what they need to do.
Right, and there's a lot of organizations out there. I'll keep it brief, but a lot of organizations out there. But what I tried to do is in this website, 38lemon.com, it's from a brain cancer awareness, but from the perspective of a patient. And so it's journals every day. What's it like going in, coming out of surgery or chemo? And art and photographs and all these different things that allow people to grasp when they're first starting.
And it's incredible that in that website you have a graphic that says that there are probably 1 million people walking around with a tumor that don't know it. And that if they all could get an MRI, it might be solved and we might be able to save them. Nonetheless, as time goes out, I want to thank you all so much for joining us. You've got great stories, you're courageous and wonderful, and I'm sure you've learned a lot listening to their stories. I thank you, Dr. Watson. And I thank you for watching, and until the next time, I'm Dr. Russell Libby, looking out for your health.